Prostate Cancer Awareness Month, and BPH affects about 50% of men between the ages of 51 and 60, and up to 90% of men older than 80. Tonight, urologist Dr. Ali Saram will be discussing the risk factors and treatment options for BPH and prostate cancer. To our viewers watching the live stream, please type your questions into the comments section and we'll answer them at the end of the presentation. And now I'll go ahead and hand it over to Dr. Saram. Thank you.
Great, thank you. Thank you, Hillary, and thank you to Skyridge Medical Center and Health One for putting together this in a series of presentations that we have done to try to educate our community about men's health, prostate issues, prostate cancer, etc. Health One obviously plays an essential role in our communities, and it is really nice to have this service. I'm Dr. Saram. I'm with Colorado Urology. I'm in my 22nd year of practice. I've been in Colorado from training until now. I focus my practice in treatment of prostate disorders in men on top of other urologic issues. And so tonight we wanted to talk a little bit about what it means for men to worry about their prostates and sort of try to understand the afflictions of the prostate and what the options are and what we do about it. The format of this presentation is going to be a little bit different. I'm going to experiment a little bit tonight with myself and with our crowd here. And instead of having a slideshow, I'm going to do a more interactive show where I will actually write out my thought process. I'm going to act as if this is a consultation that I'm having with a patient. So I want you to sort of imagine yourself in a consult room with your urologist, and he or she is talking to you about urinary difficulties and sort of what it means. I'm going to ask Hillary or whoever is on the other side to let me know if I'm having technical issues or if it's not working the way it's supposed to. But with that, I'm going to get rolling. So first of all, a lot of times, we talk about prostate cancer, we talk about BPH as if they are issues of the same condition, and they are not. In reality, just a little bit of anatomy. If we have, deep in our pelvis, we have our bladder, and the bladder is a organ and whose responsibility is to hold urine. So as the bladder is filling up, it's sending signals to the brain that says, hey, I'm slowly filling up. And in return, the brain tells the bladder to relax and not squeeze and not go. And as the bladder fills up, it eventually gets to a point where it's full enough, and it tells the brain that I have to go. It's a positive signal to the brain. And in return, the brain sends a signal back down to the bladder and says, squeeze. So it says, go ahead and push to get the urine through. And it tells the outlet, whatever is in the outlet, which includes the prostate and the muscle beneath the prostate, to relax. So it is both a signal that says to the bladder, work, and it says to the prostate and the pelvic floor musculature, this is the muscle that holds urine, to relax. And in doing so, the prostate opens and the muscle opens, so urine can come through the urethra. This happens in men because we have prostates, and in women, since they don't have a prostate, that happens at the level of the pelvic floor muscle only. And so by virtue of where the prostate lives, unfortunately, it has an effect on the urinary function that men experience. Now, the prostate itself is a reproductive organ, meaning that the function of the prostate is to produce semen, and pardon for the doctor handwriting, but I'm doing my best, and to transport semen. So really, the only function of the prostate is produce semen, transport semen. It's a reproductive organ. Once a man is done with his reproductive function, he really does not need a prostate. Now, having said that, by virtue of where the prostate lives, near the bladder and actually surrounding, like a donut, surrounding the urethra, the prostate tends to have an effect on the urinary function. And then on top of that, nerves and blood vessels that travel along the prostate. So you have nerves and you have blood vessels that travel along the prostate on their way to the penis. They function in a, to help with erections and for sexual function. And so by virtue of where the prostate lives, it also has a sexual function. But in reality, it's just a reproductive organ. Now, what happens is as men get older, there's two conditions of the prostate that we tend to develop. One is we can develop cancer of the prostate. And the second is that we can have an enlargement, or in reality, a tightening of the prostate, which results in urinary difficulties. And when we have enlargement, we call that BPH. And BPH means benign prostatic hypertrophy, or enlargement of the prostate. Prostate cancer is, as you can imagine, abnormal cells that develop within the prostate that can eventually cause troubles in terms of those cells growing and spreading and causing other troubles. The issue is that a lot of men conflate the two. They think that, hey, I don't have any symptoms, therefore I probably don't have cancer. Or they say, I have symptoms, I have an enlarged prostate, so I must have cancer. It's really important in our minds to separate the two from each other. Yes, they can happen together, and oftentimes they do, but one does not necessarily lead to the other. So it's important to sort of keep that in mind. Now, talking briefly about prostate cancer, since it's a Prostate Cancer Awareness Month, we do screening for prostate cancer. It's kind of a long conversation that's beyond the scope of this topic tonight, but we screen for prostate cancer. So the first topic is prostate cancer. And we screen for it by doing an exam, which a lot of times people have gotten away from doing, but urologists still believe in that periodically a man should have a digital rectal exam to check for sort of consistency of the prostate and make sure there's no lumps or bumps or masses on the prostate. And we screen for it with a blood test called a PSA. So if there's an abnormality on the exam, or if there's a rise in PSA, we do further workup. Now, this further workup, it could be a lot of different things. It can be an MRI of the prostate, it can be urine markers, and eventually it is a biopsy of the prostate. And then depending on what it shows, then we talk about various options, including observations or treatment, whether we do radiation or we do surgery or whatever it may be. And actually on my YouTube channel, there's a whole other talk that we have on prostate cancer screening and treatment and sort of a prostate cancer consult. And, hopefully we can someday share that with you. So that's what happens with prostate cancer screening. And it's very separate than what happens with BPH. So the second problem is BPH. Now, what happens with BPH? As the prostate grows, so back to our schematic, there's the bladder, here's the urethra, there's a prostate that wraps around the urethra. And as the prostate grows, it puts pressure on the urethra. It takes a stranglehold on the urethra, which builds pressure back up into the bladder. And it causes the bladder muscle to become increasingly more irritated and thickened. And so when you have a prostate evaluation, your urologist may tell you, hey, your bladder wall has become thick and irritated. And that's because the bladder is a muscle. And if the muscle is working against resistance, eventually it thickens and it may quit working. And so what ends up happening is over time, if obstruction is not treated properly, the bladder may give out. And so the way we sort of screen and talk about prostate cancer is we do several tests. And so And actually, before we talk about the test, let's talk about the symptoms. And so what happens is when people have BPH, they have obstruction. And as a result of the obstruction, they may develop symptoms. And the symptoms are generally in two categories. They are either storage symptoms or they are, flow or outlet symptoms. And so people develop, for example, urgency, frequency, irritation, pain with urination, um, getting up at night to urinate several times. These are all symptoms that men develop because the prostate is causing blockage of the bladder is getting irritated, and it stops working normally. Remember this initial schematic of the brain and the bladder working in conjunction? When a bladder is obstructed and it gets irritated, the signals going to the brain and back down from the brain become mixed up. And so people develop those irritative voiding symptoms. Frequency, urgency, getting up at night to pee, leakage, things like that. And then on the other hand, there are flow issues or emptying issues, including slow stream, dribbling, takes a while to get things started, and not emptying the bladder properly. And so men say, oh yeah, I go to the bathroom, I got this terrible urgency, and by the time I get there, I try to get started, I can't get started. It takes a while to get it going. I have to push to get the flow going. And once I get it going, it sort of dribbles and it starts and stops and it doesn't want to go. And so men can have both storage and flow symptoms independent of each other or together. Oftentimes it starts with those irritative symptoms and eventually it leads to those flow type symptoms. And so the consequence of that is that not only are there symptoms that are bothersome and they affect the quality of life in men, but there are also consequences to the function and health of the bladder, because again, this is a muscle that if it's not treated properly, the muscle eventually gives out and it quits working. So as a urologist, I'm really concerned about your symptoms. I want to make sure that we maximize your quality of life, but we also are worried about the health of your bladder, making sure that your bladder is going to be healthy for the long run. And so when you see us for an evaluation, we oftentimes, obviously, as with any other medical condition, we do a history, we do an exam, we check a PSA because we want to know that this is not somehow related to cancer or associated with cancer, or want to make sure there's no cancer while we're doing this stuff. We do a urine test, a urinalysis, because we want to make sure there's no infection. We want to make sure that there's no blood in the urine or some other issues. And then we do a series of tests. And the very first test that we do, and test that we do often when you see us, almost on every visit, we do something called a post-void residual, PVR. So you're going to hear the urologist talk about PVR, PVR, PVR. A post-void residual is an ultrasound, sort of a handheld small ultrasound that we use to measure how well your bladder drains. So as the bladder gets tired, it quits draining efficiently. And so whereas a normal bladder drains to completion, a person with BPH that's not treated starts to retain more and more and more fluid. And so we use the PVR as a gauge of the health of the bladder. And we also use it as a gauge to see how things are progressing, whether you're getting worse or better, depending on what treatment we're choosing to do. Now, in addition to the PVR, we also do oftentimes a flow test. So we have you come with a full bladder and we have you urinate in a special urinal that measures the flow of urine. It measures how much urine comes out, and it measures how fast and efficiently that urine comes out. And that's a surrogate for the degree of obstruction and also the health of your bladder. And there are different ways of doing the flow test, but they all do sort of the same thing. There's a test called urodynamics that we sometimes choose to do. The urodynamic test is a fancy flow test that also measures the health of the bladder and the function of the bladder, and also measures the function of the electrical signals and how well your bladder and the brain coordinate with each other. So if necessary, we often recommend a urodynamic test to try to figure out what's what. We also do an ultrasound to measure the size of the bladder. That's or size of the prostate. That's very important because depending on how big the prostate is, you may qualify for different medications and you may qualify for different types of interventions. And so that's important for us to know what the size is. And ultimately, we take a look in the bladder in a procedure called cystoscopy. Now, everybody dreads that procedure because what we do is we put some numbing gel inside the urethra. We run a scope in to the bladder and look around. It's an outpatient procedure. It's done relatively quickly. Yes, it's a little bit uncomfortable, but most people, when it's all said and done, say, yeah, you know, it wasn't as big a deal as I thought it was going to be. It's very important for us to do cystoscopy. With cystoscopy, we're evaluating the shape of the prostate and we are ruling out other diseases like bladder cancer, like scarring inside the urethra, stones in the bladder, and other issues. And so it's really important for us to complete that workup. Now, do we always do a workup right off the bat? No, oftentimes we start the treatment, but then we move people on to the workup because we're trying to figure out what the best way is to try to treat this or to try to address the condition. So that's what we do in general to try to evaluate men with BPH. Now, let's talk about a little bit about sort of our thought process and our algorithm of sort of how we evaluate this condition. The way this is categorized is the overarching diagnosis is lower urinary tract symptoms. We call that LUTS. Lower urinary tract symptoms acknowledges that when men have urinary difficulties, it's oftentimes and majority of the time due to their prostate. It's a BPH problem. But sometimes this can be a bladder issue and not a prostate issue. And people can develop an overactive bladder independent of blockage. If the nerves aren't working properly or if there's other conditions that cause that. And so it's really important for us to try to differentiate. Is this a bladder problem or is this a prostate problem? Now, to complicate matters, prostate problems oftentimes lead to a bladder issue. And so you can have symptoms that are mostly, point to the bladder, like urgency, frequency, but the underlying cause could be BPH, could be your prostate. And sometimes you can have them independent of each other. So we treat the prostate, but then the bladder symptoms persist, and then we got to treat the bladder symptoms separately. So it's really important to have this sort of construct in our mind as we're trying to decide on where to go. Now, when people come in with urinary symptoms in men, the assumption is that this is a BPH problem. And so oftentimes, we do the testing as we just talked about. We go through all of this stuff. The other thing that I forgot to say in the evaluation, you also fill out a questionnaire. It's called IPSS. It's kind of a goofy questionnaire. It's 6 questions, and it talks about your symptoms, and it says how badly are they bothering you, how often is it happening. It's really important that when you're faced with that IPSS questionnaire, that you actually try to pay attention and try to answer the questions as truthfully as possible, because we actually rely on that IPSS a lot. Our guidelines guide us to how we should treat people depending on the IPSS score, and we use it as a way to know how well our treatments are working. So then, you come in, you have this evaluation, we assume this is a BPH problem, and so we always give people a trial of medications. Now, a little bit about sort of my practice philosophy. I think medications are fine, but medications are chemicals that sometimes treat the problem and oftentimes treat the symptoms without treating the underlying condition. And so nothing wrong with trying medications, and if medications are effective and if they work well, we can keep you on it long term. But my personal philosophy is that if there's a way to fix the problem, we try to fix the problem without keeping people on medications long term. Now, in the medication world, there are 2 classes of medications. There are alpha blockers, so you may hear this term, And a common medication in the alpha blocker category is tamsulosin or Flomax. So you may be on it, you may have heard about it, you may have taken it, but tamsulosin is one of the main medications we use in that class of medicine. The second class of medicine is called a 5-alpha reductase inhibitor. Don't worry about that, but it's just a different class of medicine, and a common medication in that class is finasteride. Now, there are other medications in each class, but those are the medications that you oftentimes hear about and you may already have taken. Now, those two do different things. Tamsulosin relaxes the prostate, whereas finasteride physically shrinks the prostate by changing the hormone milieu that the prostate lives in. And so it's important to, again, know which medicine you're on and the reasons why you're on them. All medicines, all chemicals have side effects. And so the main side effects that people experience with tamsulosin is sometimes dizziness. So when you stand up, you may feel lightheaded or dizzy, and God forbid, become unsteady or fall over. And so we take it very seriously, because as people get older, they get unsteady anyways. They're prone to accidents. And the last thing we need is an old man to get up to go to the bathroom middle of the night. They get dizzy, they fall, they break a hip, and all the consequences associated with that. So we don't take this lightly. We always start people carefully, but frankly, most people tolerate it pretty well, and there's ways to try to minimize that side effect. Tamsulosin can also cause a bit of nasal congestion, so you feel like you got sort of allergies. That's not a big deal, but sometimes people are really bothered by that. And lastly, about a third of the people who take tamsulosin report retrograde ejaculation. So when you have an orgasm, less fluid comes out or no fluid comes out. That's not a dangerous condition, but it feels weird, and oftentimes men don't like it. And so if that happens, please report that to your physician and report to them whether you're bothered by it or not, because that may change sort of what they end up doing with that. Finasteride, on the other hand, changes the prostate hormonally, so it can have some other unique side effects. Like people who are on finasteride long-term can sometimes develop a little bit of breast tenderness and a little bit of a growth in their breast tissue. It can cause a drop in libido, and it can contribute to sexual dysfunction. And then there are some other sort of observed side effects of tamsulosin and finasteride, and when people are on this long-term. So having said that, long story short, medications are effective. They treat symptoms. They don't necessarily treat the underlying condition, although sometimes they do. They have associated side effects. And if possible, we'd like to test people on a medication, but not keep them on it long term, because we're trying to figure out what's what. And so in our algorithm, we get people on medications, and then we have them come back. And if they're super happy and all is good, we keep them on medicines. But oftentimes, we proceed with the testing that we talked about previously, these tests up here, the cystoscopy, the flow test, the urodynamics, the ultrasound, whatever we think is necessary to try to understand what's going on. And the tests, partly is because we want to make sure that we're barking up the right tree, so to speak, to make sure that this truly is a prostate problem. We're trying to differentiate the prostate or whether a bladder issue, so we're trying to differentiate that. We're also trying to rule out other conditions like bladder cancer or stones and other issues. And this is a plug, and I wanted to sort of mention this. There are other specialties that have now started to really focus on on the prostate and urinary problems in men. For example, our colleagues in interventional radiology, they have access to this unique procedure that they do that we're going to talk about in a few minutes. And so they advertise pretty heavily. It's called prostate artery embolization. They advertise pretty heavily. They try to draw patients. Nothing wrong with that. The PAE has its role. It's effective in some patients, and certainly we refer patients to go for a PAE with our radiology colleagues. But as a matter of principle, urologists are against the idea that patients should go to radiologists primarily without a urologic evaluation, because the radiologists will not do the testing that we talked about above, and they will not rule out other conditions like bladder cancer or urethral stricture and other stuff. And all of us have stories of patients who've had repeat PAEs, and then they came back to see us, and we did testing, and we found other things, including bladder cancer. So my urge, I really want to urge our patients to say, hey, if you want to go get a PAE, great, but first see your friendly urologist to make sure there's nothing else going on before you have that done. So we do these tests, and then depending on what we find on the test, we go on to treatment. And in the treatment world, there is the minimally invasive therapies. So we call that, minimally invasive therapy. And there are surgeries that we do. And it gets a little bit confusing because there are so many options in both of these categories. I'm going to try to get into that a little bit. So in the old days, it used to be, medications or go straight to surgery. And nowadays, we go from medications to tests to potentially minimally invasive therapies. Now, not everybody qualifies for a minimally invasive therapy, but certainly a lot of people do. And in the minimally invasive world, it seems like every day there's a new procedure that comes out. And there are procedures that become popular and then they fall out of favor and they go away. And so you may have had things like a microwave therapy or a tuna or some other things that are really no longer done. In this day and age, 2023, the minimally invasive world consists of either a procedure called Urolift. And with Urolift, what we do is we go place these permanent implants inside the urethra to open the channel. And so what we do, and again, this is sort of, I can't really draw it out as well, but if you think about it, if this is the prostate, and we, in the previous pictograph, and this is the urethra and the bladder's up here, the prostate is growing in. And so what we do is we look inside and we place these implants into the prostate. And the implant basically has an anchor that goes on the outside of the prostate, has an anchor that goes on the inside of the prostate, and it squeezes the prostate tissue between these two anchors. And we do that in several spots along the prostate. And in doing so, we essentially open up the prostate channel. And these implants heal into the prostate and then open up the channel. It's actually a very clever procedure. The tagline is a mechanical solution for a mechanical problem, which I think is pretty accurate in what the procedure is trying to accomplish. For the right patient, the right size, and the right shape prostate, with the right goals, the Urolift is a perfect option. Now, there's a lot of nuances in who qualifies for a Urolift and who doesn't, and that is really up to you and your urologist to discuss when you have this evaluation. Besides Urolift, we do a procedure called Rezum. In a Rezum procedure, we inject steam into the prostate. And so what we do is we look in the prostate, and there's a device that has a little needle tip that goes into the tissue. It injects hot steam into the prostate, and in doing so, it damages the prostate tissue and shrinks it, and the shrunken prostate tissue kind of scars away from the middle, and it opens up the channel. It's a good procedure, again, for the right size, right shape prostate. I would say that the Urolift and Rezum kind of overlap, and it depends on your doctor's experience and their desires and their preferences and which one they do. But for the most part, if you qualify for a Urolift, you also qualify for a Rezum. There's a new procedure that is sort of being done, but not greatly, and it's a procedure called iTind. And iTind is a temporary implant. So what happens is you come in, you have this implant placed inside the prostate. You walk around with that for 1 week, and then you come in at the end of the week and have the implant removed. And what the implant does is it squeezes the prostate tissue open, creates a channel. It creates a little bit of a scar inside the channel. So when the implant is removed, the channel remains open along those scar lines. It's relatively new. It's not greatly covered by insurance, and there are places around town, including our practice, that do it. There's not a lot of experience with it, and so it just remains to be seen how well it will work in the long run. And lastly, what we do is we do this prostate artery embolization, PAE. And this is the procedure that is done by our interventional radiology colleagues. And so what they do is they go through your blood vessels as if you're having a cardiac catheterization. They find their way through the blood vessels to the area of the prostate. They find the blood vessels that feed the prostate, and they stop the flow of blood to the prostate by blocking those blood vessels. Now, what happens over time is the prostate, which is starved of blood, will eventually shrink, and as it shrinks, it opens up and it helps the symptoms. And we've seen that, at least in the short run, PAE seems to be pretty effective for a lot of people, but not everybody. And so again, leave it up to your urologist to do the proper workup and to try to guide you to see if PAE is potentially a good option for you. If your urologist doesn't offer PAE, you can always seek opinion of somebody who does, including our practice. We do a fair number of PAEs, but for the appropriate patients. PAEs tend to work a little better for big prostates, and durability is a little bit questionable, although durability with most minimally invasive therapies is not as good as the surgeries. So nevertheless, you may choose for a minimally invasive therapy. Depending on size and shape of your prostate, you may qualify for a Urolift, a Rezum, an iTind, the PAE, and there are other therapies that are becoming available every day. And so your urologist may have access to other things, or you may see other procedures advertised. But for the most part, the idea here is that we want to preserve the tissue. We don't want to cut any tissue. We don't want to do surgery. We want to try to allow people quicker recovery with less catheter time, and we want to sort of get people on the road more faster than we do with surgeries. So we do these minimally invasive therapies, again, the right procedure for the right patient. I'm going to get to sort of the experience of how it works here in just a minute. Now, if you don't qualify for a minimally invasive therapy, or if the minimally invasive therapy doesn't sound right, we can also do surgery on the prostate. And the idea behind surgery is to remove the inside of the prostate. So no matter how the surgery is done, if this is the bladder, this is the prostate, and this is the urethra inside the prostate, we go in and we remove tissue inside the prostate. And in doing so, we create a wider open channel. And so now urine can go through more easily. And so what happens is we remove the tissue inside the prostate, creates a bigger channel, the urethra forms in a bigger chamber, and so urine can flow through that chamber more easily. That's how surgery works. Now, there's a million different ways how we do this surgery, and you're going to hear all sorts of different options. The reality is they all eventually accomplish the same thing. In the surgical world, sort of the gold standard and what we have done forever and ever and ever is a procedure called a TURP, TURP. Now, a TURP, is commonly also referred to as a roto-rooter, which kind of makes it sound terrible. And also, it was a very commonly performed procedure 20, 30, 50 years ago even. And the outcomes weren't quite the same as what they are now. So today's TURP is a very different procedure than what your father or your grandfather may have had. So if your urologist talks about a TURP, please don't worry. This is not going to be the type of procedure that you may have heard from other people, and the war stories they may hear from people a generation or two past is probably not really applicable anymore to today's TURP. So with a TURP, it's a procedure that we do where we go and trim out the inside of the prostate, and there's a lot of different ways that we can do that. We can use laser as a source of energy to remove the tissue. We can use a monopolar electric energy. We can use a bipolar electric energy, which is what is done most times anymore. And, there are other ways of doing it. And so, your urologist may choose to use a laser. They may choose to use a bipolar electrode. Again, it really doesn't matter. The companies that make these things, I'm being very honest, they try to make a big distinction. They say, well, laser is better than electricity. There's fewer side effects. Yeah. It all is the same. Your experience will be the same. The end result is the same. Risk of bleeding or complications is the same. Essentially, you end up with a prostate with a wider channel, and you're going to be happy with the flow and the urination, regardless of what you choose to do. Now, in my practice, I use the bipolar electric energy. I've done lasers a lot in the past, and at least in my hands, the laser doesn't remove enough tissue, and there's a higher risk of having to go back to the operating room to do more surgeries. And frankly, I don't see a lot of benefit to it. So I just, I've gone back to the old bipolar electric source, which for me works beautifully. Besides a TURP, you can have a procedure called HOLEP. HOLEP is a holmium laser enucleation of the prostate. So instead of trimming out the inside of the prostate, we enucleate the inside of the prostate. Same end result. We can probably remove a little more tissue with a HOLEP than we do with a TURP. The problem with the HOLEP is there's not too many people who do it really well, and it is a difficult procedure to learn and master. And at the end of the day, it probably doesn't offer a lot of advantages over a TURP, especially given the fact that there are some other options for larger prostates and other issues that the HOLEP was sort of designed to do. And so in our practice, we don't do any HOLEP yet, and partly because we don't see a reason or a role for it necessarily in this day and age. You can have a robotic, simple prostatectomy. And a robotic simple prostatectomy is where we use a surgical robot. We go through the abdomen, we go through the bladder, and we open up the bladder, and we approach the prostate from above. So instead of going from the urethra, which is what all other forms of surgery do, we actually go from above. We go from the bladder, and we scoop out the inside of the prostate. The robotic simple prostatectomy is a great procedure. It works really well. It removes a lot of tissue, and it's best for very large prostates, because those very large prostates, you can't do them justice with a TURP by not, because we can't remove enough tissue safely. And so then we have to go do a robotic simple prostatectomy. It's a little more invasive, a little longer recovery time, and perhaps, more sexual side effects. And so when necessary, we do a TURP, and when necessary, we can talk about doing a robotic simple prostatectomy. And lastly, it's the procedure that I'm very passionate about. It's called an aquablation. An aquablation is a transurethral surgery, so it goes from below, from the urethra, and it uses a high-power water jet to trim the tissue using ultrasound as a guide. And it's the first procedure that we have in urology where we use ultrasound. So we use imaging as a guide to see what we're working on. All other procedures above, we use visual cues. So we're looking, we say, yeah, that looks like that's the part of the prostate that needs to go. And so we cut on it. Whereas with an aquablation, we use ultrasound to identify the parts of the prostate that are problematic, and we do that at the beginning of the procedure. We feed that information into a computer that calculates what parts of the prostate need to be sprayed out. And then there's a device that goes through the urethra, the tip of which has a water nozzle that sprays saline at very, very high pressure, and it trims the tissue accurately and precisely based on the data that we had put into it based on our ultrasound evaluation. It's a procedure that's done at the hospital, and it's done under a general anesthetic, so you don't know what's happening. But when you wake up, you have a catheter in your bladder, as you would with all the other procedures above, a TURP, a HOLEP, robotic simple prostatectomy, aquablation. All of them requires a catheter in your bladder. All of them have a catheter that's hooked up to a little irrigation that washes out the inside of the bladder, because all these procedures can cause some bleeding, some blood in the urine, which eventually stops, usually within a day or two. But nevertheless, we can't just let it bleed, and because it will clog up the catheter and cause troubles. And so we wash out the blood. And sometimes you go home same day with all these procedures, and sometimes you spend 24 to 48 hours in the hospital on that irrigation. With all of them, you go home with the catheter, and some of them the catheter comes out in 2 or 3 days. Some of it the catheter comes out in 10 days, like a robotic simple prostatectomy. And with aquablation, on average, catheter comes out in 3 days. Now, all of these procedures are obviously more invasive, and they are a little bit more of a commitment from the patient, because it's a hospital stay. It's sometimes outpatient, sometimes hospital, but it requires an anesthetic. It requires a catheter. It requires a little bit of time off, and it requires a period of healing for a few weeks afterwards until the insides had a chance to heal up. So why would anybody choose these more invasive therapies over the minimally invasive therapies? Well, sometimes you don't qualify for the minimally invasive therapies based on the size and the shape of the prostate. And sometimes people are asking for better and more durable outcomes that you can't achieve with the minimally invasive therapies. And so the way I counsel my patients is I say, let's put all these on a list, and let's talk about various things that can happen. So we talk about Urolift, Rezum, PAE. I don't put I-10 down there because we don't have a lot of experience with that quite yet. Talk about a TURP. We talk about a robotic simple prostatectomy and aquablation, right? So these are sort of the menu of options, and assuming somebody qualifies for all of these, then what is the experience? And so the first, factor that we look at is, is it outpatient or is it a hospital stay? And so a Urolift is outpatient. You go home same day. So I put outpatient. Rezum is outpatient. You go home same day. PAE is outpatient. You go home same day. TURP is many times outpatient. And sometimes, so I say plus minus, because sometimes people spend the night in the hospital. A robotic simple prostatectomy is usually about a 2-day stay, 1 to 2 day stay at the hospital. And an aquablation is a usually 0 to 1 day stay. So sometimes people go home same day, sometimes people spend the night in the hospital. The next thing that distinguishes these procedures from each other is whether a catheter is necessary or not. This is a catheter that comes out the penis. With Urolift, plus minus. Sometimes we have people go home without a catheter, and sometimes we have people go home with a catheter, and at most, it's usually around 1 day. So not a big deal. Overnight, and the next day it comes out. With Rezum, every urologist has a different protocol, but it's usually 3 to 5 days of catheter. Because what ends up happening is when we inject all the steam in the prostate swells up, and it takes a few days for that swelling to slowly go away and for the prostate to start shrinking, etc. So we leave a catheter in for 3 to 5 days. With a PAE, it's usually none. People usually go home without a catheter, although sometimes the prostate swells up and then they have to have a catheter put in for a few days. With a TURP, it's 3 to 5 days. So again, depends on who does it and how it's done and what the desires are. Sometimes we take it out the next day if the urine is really clear and if the procedure was really straightforward, but nevertheless it requires a catheter. Robotic simple prostatectomy is usually 7 to 10 days because here we open up the bladder and we have to allow the bladder to heal, so we keep a catheter in longer. And an aquablation is usually around 3 days. So again, a little bit of a distinction. with these minimally invasive therapies, less catheter, more invasive therapies, more catheter. Now, the thing that we look at, most importantly is, how effective are these procedures? So efficacy. So how effective are they? How well do they work? And there's a lot of different ways of measuring efficacy, but in general, the arrow goes this way. The more invasive you become, the more effective the procedure is, because it makes intuitive sense. We're removing prostate tissue. And so if you remove prostate tissue, there's bigger channel and there's going to be better results. So in terms of relief, better flow, better emptying, less urgency, less frequency, less getting up at night, clearly is in favor of a more invasive treatment. No question about that. The other thing that we worry about is durability, meaning if you do the procedure, how likely are you to have to do it again? And durability, unfortunately, is measured in a lot of different ways. But probably the best way to look at this is, what is the 5-year retreatment rate? Meaning, over 5 years, what % of people have to do something else after they've done one of these procedures? And if you really look at the data, and the data is not very clean, there's a lot of sort of mixing of conclusions, and there's, frankly, a little bit of marketing and a little bit of stuff that goes on. But nevertheless, the more invasive the procedure, the more durable it becomes. And so when you look at the Urolift over 5 years, about 13% of people. So after a Urolift, about 13% of people have to be back on medications, and another 13 to 15% of people have to have another procedure. So, probably about a third of the people end up being back on something, another procedure, or being back on medicines. Now, you can look at this negatively, or you can look at it positively. 70% of people 5 years out are still free of having to be back on medicines or have to have another procedure, with a very minimally invasive procedure that actually fixes the problem. And I think that's the charm of a procedure like Urolift or Rezum. And I think Rezum data is about the same. Their data, they claim, is a little bit different, a little bit better, but really when you look into it, it's about the same. So about 13, 15% of people end up doing something again after 5 years, or over the next 5 years after they've done a Rezum. And some people look at this and they use that as a way to criticize these procedures. I look at it positively. I say, listen, 70 to 80% of the time, you're still free of any medications, any chemicals in your body, or need for other procedure, and you still have relief even 5 years after a minimally invasive procedure. And so the analogy I use is I say, hey, if somebody has to be on a cholesterol medication because they have high cholesterol, and if they have the option of doing a minimally invasive day procedure that keeps them free of medication or free of another procedure, let's look at the worst numbers, 70% of the time over 5 years, that seems really attractive. For me, I would do it. I would say, hey, I'll do the procedure, even if it means that 30% of the time I may need to get back on a medicine or do another procedure. 70% of the time, I'm free of all this stuff for 5 years. I think that's great. Now, it doesn't mean these things work only for 5 years. It just means that we've looked at it out to 5 years. And so think of it that way. Yes, it's not perfect, but in reality, it gives you great relief for a very minimal commitment. Prostate artery embolization, similarly, very effective. The retreatment rate, because it's a newer procedure, there's not enough data. There's a couple of papers that talk about 20% retreatment over 2 years. And again, not great if you look at it negatively, but if you look at it positively, here you have an outpatient procedure that 80% of the time has kept you free of reintervention, at least over 2 years. And I think as we look at it longer, those results are probably going to hold. And so not bad, frankly. A TURP, the retreatment rate over 5 years, data is a little bit mixed, but somewhere in the 6 to 10% range. They have to have back on medications or have another surgery. Robotic simple prostatectomy, probably around 5%. And an aquablation, probably around 3 to 5%. I always pick the higher number. So again, great durability. So only 95% of people who have surgery on their prostate over 5 years are happy. They don't have to do another procedure. They don't have to get back on medications. That to me is a very successful surgery that really fixes the problem. And then lastly, we talk about some of the side effects. And there's two main side effects that people stress about with prostate procedures. One is erectile dysfunction. So what percent of people develop new onset erectile dysfunction after a procedure on the prostate? Now, common things being common, old men get BPH, old men get erectile dysfunction. So it's really hard to say that the erectile dysfunction developed because of the prostate or because of the procedure. But for people who had the procedure and they came back 2 weeks later and they said, I used to have perfect erections before and now suddenly I can't get an erection, maybe, maybe that was because of the procedure, and probably was if it happens that quickly. Frankly, we rarely see that, but nevertheless, if you look at the data, in Urolift, 0% of people develop new onset erectile dysfunction after a procedure. With Rezum, it's anywhere from 0 to 3%, so it's actually very good. With a PAE, it's very low, so again, we don't know the data for sure, but it's got to be less than 5% because it appears to be approaching that 0%. With a TURP, hard to measure for sure, but right around 10% of people probably have a risk of developing erectile dysfunction at some point after the procedure. Robotic simple prostatectomy, probably a little bit higher than that 10% range because it's a little bit more surgery. We're a little bit closer to those nerves and all that stuff. And with an aquablation, it's 0 again. So there's no known new onset erectile dysfunction after an aquablation, and that's one of the advantages of this procedure. And then lastly, the thing that I talk about my patients is ejaculatory dysfunction, EJD, meaning you have an orgasm, but no fluid comes out. Again, not dangerous, but it happens, at some point, and sometimes people are bothered by that. With Urolift, 0%. With Rezum, about 3%. With PAE, as best as we know, it's less than 5%, but we don't know for sure because, again, that data is not super accurately collected. With a TURP, it's greater than 50%. So you go mess with the prostate, there's going to be a pretty good chance that you develop ejaculatory dysfunction. Some people don't care about it, but if you really care about that, you better have a conversation with your urologist so you're not disappointed. With a robotic simple prostatectomy, most definitely greater than 50%. And with an aquablation, it's around 15 to 20% rate of developing that. And so lastly, I want to contrast that with medications, because if you're on a medicine, is it outpatient? Yes, of course it's outpatient because you take it at home every day. Catheter, hopefully not. Effectiveness, plus minus. Medications are somewhat effective. They improve the flow. They relieve symptoms. They don't really cause the problem, but they cover up, or they cure the problem, but they cover up the symptoms. Retreatment rate is 100% because you take a medicine tonight, you got to take it again tomorrow night. And so I sort of tongue-in-cheek tell my patients, hey, listen, if you're on medicines, you have a 100% retreatment rate because you got to take it again the next day. It doesn't fix the problem. You got to take it for the rest of your life. Erectile dysfunction happens. Again, the data is not super clear, but it can happen in, probably about 10 to 30% of patients. And then ejaculatory dysfunction, depending on the medication that you're taking, is 30%, plus more than 30%. And so clearly medications have side effects that some of these procedures don't have. And so I usually present this chart to my patients. I know this is getting kind of long, but I present this chart to my patients and I say, let's pick. Now, based on the size and the shape of your prostate, you may not qualify for Urolift or Rezum or PAE. And we may have to do a resective procedure, a TURP, a robotic simple, or aquablation. And then we compare TURP versus robotic simple versus aquablation. And we say, which is the procedure that's going to give us likely the best results? And at least in my hands, aquablation seems to be the answer. Now, of course, the TURP is a great procedure. And so if a patient says, doc, I don't care about my ejaculations or erections because I've got pretty bad ED already, and I just want to do an outpatient procedure and get it over with, we go do a TURP. It's a great procedure. It works wonderfully. It's outpatient, and it works well for the right size prostate. Sometimes people say, no, I really want to try to preserve my ejaculation as much as possible. And then we go do an aquablation, understanding that it can still happen in 15 to 20% of patients. Some people have a smaller prostate, so they qualify for all the above. And they may say, yeah, I really want to do something that's outpatient. I can accept a risk of retreatment. I can accept that it may not have quite the oomph that a surgery does, but I want to do something less invasive. I want to do a Urolift or a Rezum or PAE to get started with. And then eventually, if we have to do something else, we can go do a TURP or do a resective procedure. So really, this becomes a conversation between you and your doctor, and we have to sort of tailor the treatment to your problem, to your anatomy, and to your desires and risk and tolerance for risk. And so this is sort of the big picture of how we counsel patients when we talk about their BPH issues. Lastly, I really want to make sure that you have access. Most people who are on this call probably already have a urologist. So my urge to you is go see your urologist and see them frequently, at least yearly, because even if your urinary symptoms are well controlled, your urologist is going to want to know that your bladder's healthy, and they're going to want to check and make sure you're not developing cancer of the prostate. And so frequent or at least a regular follow-up with your urologist is essential. If you, it's not Urolift, sorry, it's urologist. See your urologist. If you don't have a urologist, please see one of my partners or myself, Colorado Urology. Colorado Urology, we have offices up and down the Front Range, and from Boulder all the way to Castle Rock. We have over 20 board-certified doctors, most of whom focus and have a big practice in BPH and prostate cancer, most of whom do all the procedures that we talked about above. And so it's really important for you to go see one of us. And if you want to come see me, that's great. Our phone number, at least to come see me, and we have offices everywhere. So we have an 800 number that you can see on our website, but you can also call a number, and it's 695-6106. And I'm Dr. Saram. And again, you can see any of my partners to get this taken care of. And so it's, again, very important that you have proper evaluation, proper follow-up. We would be happy to see you and figure out what is best for you. And with that, I'm going to stop this presentation and I will turn it over to Hillary for any questions or any other conversations. And thank you very much. I really appreciate everybody.
Thank you, Dr. Saram. That was really wonderful. That was great information. I'm just going to give it one moment to see if there's any questions in the comment box for those who joined us on our WebEx. And I don't think so, but that came in. So I'll just go ahead and ask and then give you a moment to answer or elaborate on something you may have already talked about. So which procedure is the best to maintain sexual function?
Okay, so that's a great question. So let's go back to this table. So sexual function in terms of erections or ejaculation. So it's really important to keep in mind what you mean by that. Now, oftentimes when men come in, they have baseline erectile or ejaculatory issues, and no procedure is going to make that better. So again, have realistic expectations. If you already have some troubles, you're likely going to continue to have those troubles. That's a separate problem that can be treated very successfully, but that's a whole separate conversation. In terms of new onset erectile dysfunction, it's clearly in favor of the minimally invasive therapies, Urolift, Rezum, PAE. The more invasive therapies, Aquablation seems to do better than the other alternatives. Now, the rates are relatively low, less than 10% or thereabouts at most, but nevertheless, I'll take 0 over 10%. I never in medicine believe in 0 as a statistic, because the studies show, they suggest 0, but there's always that one patient who comes back and says, after the surgery, maybe things aren't quite as good as they used to be. And then it's really hard to decipher. Is this something that was developing already? Is it, the surgery that does it? But, make a long story short, the minimally invasive therapies do better than resective therapies within the resective world. Aquablation does better than its competitors. But you also want to go back and sort of talk about your goals. Is the goal to minimize complications? Yes, of course. The goal is to try to improve your urinary symptoms, preserve your bladder health, and give you longevity. And if there is a risk of ejaculatory dysfunction or erectile dysfunction, then you have to weigh that against your desires.
Okay, thank you. Kind of a piggyback to that question. So I'm relatively young. What are my best options for retaining sexual function, which you touched on a little bit, but could this treatment affect my ability to have children? And if so, should I talk with a fertility specialist?
Oh, so that's a really good question, and it's somewhat of a nuanced question. So first of all, if you're young and you're within the childbearing age, you're well outside of what we normally see for a BPH. So 30 and 40-year-olds don't usually develop BPH. That's a disease that starts sort of in the 50s and it progresses from there. And so if you have a lot of urinary difficulties to the point where you're thinking you may need a procedure, you better have a urologic evaluation to make sure there's nothing else going on. And in young people, oftentimes we find, strictures or scarring in the urethra, or we find other reasons like pelvic floor dysfunction, dysfunction of the muscles. There's a lot of other reasons why people develop these symptoms. So definitely have an evaluation. Now, if medications are not, if your doctor decides, okay, this is a BPH problem, you're outside the norm, you're a 38-year-old guy or 42-year-old guy with BPH, which is a little unusual, but if you have it, if you happen to be that one person, and your doctor says, okay, here's a list of medications, here's a list of procedures, then you got to look and see, and Urolift obviously wins because there's no risk of erectile or ejaculatory dysfunction. I think it would be a little bit of a stretch to recommend, preservation of sperm in anticipation of a prostate procedure, because it is, in 25 years of practice, I have not done a prostate procedure in somebody who was planning on having a kid. So those just don't happen. And so I'm curious to see what the underlying cause of this problem is.
Okay, thank you. So outside of age, who else is at risk?
Okay, so if you're a man, you're at risk. And as you get older, you're at risk. Obesity tends to have an effect just like it does in almost every other disease out there. So body mass index or weight, obesity is a risk factor. And frankly, a family history can be a risk factor. So if you've had family history of a lot of prostate troubles, you run a higher risk of developing that as well.